Hola to our friends from Brazil and all over the world. It's a great pleasure and honor today to be moderating this SHA Saudi Heart Association live webinar educational series, and this time we'll be focusing on important topic for dyslipidemia. It's my honor and pleasure to have two great scientists and friends locally and internationally, and both are internationally renowned for their expertise in the field of dyslipidemia. Dr. Fahad Al-Nouri. Dr. Fahad Al-Nouri is the president of the Saudi Group for Cardiovascular Prevention and Rehabilitation Group at the Saudi Heart Association. He's a leader in the field of dyslipidemia and working at the Prince Sultan Cardiac Center in Riyadh. And Dr. Raul Santos, he's an associate professor and director of the lipid clinic at Sao Paulo, and the president of the International Atherosclerosis Society. So without further ado, we'll start with Dr. Fahad Al-Nouri with his presentation. Please send your questions and make sure that the questions are relevant to the topic that will be presented. So only questions relevant will be entertained to the speaker. So Dr. Fahad Al-Nouri, please, without further ado, you can go ahead with your presentation. We'll take some questions and then we'll move on to Dr. Raul Santos. Fahad, floor is yours.
Thank you, Dr. Khalid. Thank you very much indeed. Is it clear, the screen?
Yes, great. Go ahead.
This is the center where I work in, because when I refer to PSCC, this is PSCC. These are my disclosures. Okay, familial hypercholesterolemia is an inherited autosomal dominant disease, and it's of two types, the heterozygous type and the homozygous type. They have 4 mutations, and the most common one is the LDL receptor, which dominates the 85 to 90% of cases. Then followed by apolipoprotein B100, which dominates like 4%, and the PCSK9 protein. There is which is autosomal recessive, it's LDL-RAP1, and the disease is a lifelong disease. It's since birth, so the elevation in the LDL, in some studies, it's in utero. And it's causing premature atherosclerosis cardiovascular disease, of course, because it starts in the early life. Unfortunately, 80 to 85% of individuals with the familial hypercholesterolemia remain undiagnosed. And in this slide, you can see that, is it a rare disease? No, it's not a rare disease. And as you can see here, in comparison to other genetics disease, it's in every 1,000 birth, it's 5 to every 1,000. And if you take like one most common is cystic fibrosis, it's only 0.4% of 1,000. So in common, there are 285 worldwide births per minute. If we take the value of 1 to 250 prevalence of FH, that means that one child with FH is born per minute in the world. As we said, it's underdiagnosed. Unfortunately, it's less than 5% of the patients are diagnosed. The most, the most diagnosed country is 71% in the Netherlands. And as you can see here, all the countries started from the UK, 12% and above. So in our area, MENA, which is Middle East and North Africa, what are the prevalence of the FH in
I think we lost Dr. Fahad. I think he might join again. I think he might have left accidentally.
I think he pushed the wrong button.
Yes. We'll wait for a second. I'm sure he will. Here you go. You joined again. Fahad, could you hear us?
You're muted.
Fahad?
Now, can you hear me?
Yes. Go ahead.
Okay.
Keep going, please.
Okay, so prevalence of FH in MENA, which is Middle East and North Africa, it's unfortunately not available. So our colleague, Dr. Zuhair Awan, had a study comparing the best country, which 71%, and the Netherlands reported FH, and the MENA area, and as you can see here, we are 0.01%. So Dr. Bates and his group, Dr. Al-Habib is involved. They did an assessment of physicians' awareness and the knowledge of familial hypercholesterolemia in Saudi Arabia. They just get the survey for 294 physicians in Saudi Arabia, and the response was very good, actually, it's 90%. And as you can see here, overall, 92% have poor knowledge, and 7.1% have acceptable knowledge of FH. So we come to the consanguinity in Saudi Arabia. This is very important because of the result we will show you later. It's shy under 58%. The most frequent, of course, with the first cousins, the marriage is 28.4%. Then comes the distant relevant marriage is 15%, and the second cousin marriage 14.6%. After 2 decades, our colleagues did a study showing, I mean, is that the consanguinity decreasing? Of course, because of the more education and more social media, and people are aware. The study done in 2 generations, and it was done in the 2014, and unfortunately, the consanguinity is still the same. So the spectrum of familial hypercholesterolemia in Saudi Arabia is very important. We have to know the prevalence so we can diagnose and treat this disease. And it is a prime time for patients with FH registry. So we had the Gulf FH registry, which is in press right now. It's a multi-center, multinational registry, included adults of 18 years and more. Recruited outpatient clinics in 14 tertiary care centers across 5 Arabian countries, Gulf country, which is Bahrain, Kuwait, Oman, Saudi Arabia, and the United Arab Emirates over the last 5 years. The Gulf cohort was screened, patients attending the lipid clinics, and we screened 34,366 patients. The results among those 34,366 patients, we used the Dutch lipid criteria, and the final data consisted of 3,713 patients, which was higher than the one we started with, and because we have more patients during our recruitment. So we will not go through this. The prevalence of FH in the Gulf area, the 5 Gulf Arabian countries, were 1 to 112. And this is threefold than the 2 studies done recently. One of them showed 1 to 313, and the other one showed 1 to 311. So let's talk about our experience in Saudi Arabia. This is the center. It's only one center which I'm working with, PSCC. I've got 43 families until May 2019. All of them were phenotypically diagnosed, and then we diagnosed them genotypically. We've got 104 heterozygous FH and 24 homozygous FH. Those patients, we got the proband or the index case, and then We, of course, using the NGS, the new generation sequencing, and then we got the cascades of, we include the family of those patients. You know. I will speak about Turkey. I mean, this is a very nice example. You will see the defects of underdiagnosing these cases and how easy they are slipped from us. You know, Turkey is 24-year-old when I saw him. That was like 6 years ago. His parents are first cousins, and he had, unfortunately, two brothers had CABG, coronary artery bypass grafting, at their 20s, and both died because they were not diagnosed properly, and therefore they did not receive a proper treatment. So Turkey started with, his case started with a skin lesion in his elbow, I mean, concentration, but nobody cared to just look deep into the history. Unfortunately, Turkey developed ST elevation myocardial infarction. And just to tell you that he's not diabetic nor hypertensive, and he never smoked, you know. So they did the coronary angiogram for him. They showed mid-segment significant lesion in the left anterior descending, anterior descending artery, and totally occluded lesion in the right coronary artery. He was offered CABG, but with the history of his two brothers died of CABG, he refused. He was totally adamant, and he was right. You know. So he sought medical attention in our center, and we offered him a PCI, and we did it already. You can see the stenosis here in the left ascending, anterior descending artery. And this is the post PCI, which we put stent here. And this is the totally occluded right coronary artery, and this is post PCI. So we diagnosed him genetically as homozygous familial hypercholesterolemia, and that was a novel mutation which was published. We have so many novel mutations over the years in our Gulf area, and this is very important to us. So because in the future, when we wanted to just screen patients, you know, we have some certain mutations that we can use on those patients. Of course, with the treatment of statins and ezetimibe, and I have to emphasize here that the plasma exchange or the LDL apheresis, it does not mean that the patient does not take these medications, you know, because as you know, the statins is working on the production of the statin in the liver, in the cholesterol in the liver, and the ezetimibe of the elimination in the guts. So these are his numbers before the plasma exchange. As you can see, the total cholesterol of 11.1 and the LDL of 9.0. This is after plasma exchange, which was reduced dramatically. Total cholesterol reduced by 58%, and LDL reduced by 56%. The plasma exchange has its downsides, you know, which is that you are clearing everything, especially the clotting factors. So they have tendency of bleeding afterward. So we were lucky enough to get the LDL apheresis machine. I'm not going to go through it, but you got the blood from the patient, you got the plasma separator here, and then the membrane here separates the LDL and the triglyceride and gets the blood back to the patient. This is the machine. We started Turkey in the LDL apheresis. These are his numbers before and after. And as you can see here, the total cholesterol, the LDL and triglyceride were reduced, and the HDL remained the same. You know, here is 0.96 and 0.94, while here, started with 0.94 and goes down to 0.53. This is very big change. These are the signs of the patients with the FH, homozygous especially. These are called arcus lipoides, and this is different from arcus senalis because arcus senalis is 40 and 45 and above. So if you see patients, young patients with this arcus lipoides, just make sure that you go further and diagnose them. They might have FH. Of course, the xanthoma is very important, and this is his xanthoma in Achilles. and this is after the apheresis. And xanthoma is very characteristic of the FH. You know, if it's there, the FH is there. If it's not there, it does not mean that it's not there. This is called sine qua non, like other. So if a patient with blue sclera, this is osteogenesis imperfecta. If he doesn't have it, he doesn't have the disease. But not all right or correct, except in the xanthoma. If it's there, it's easy. We can diagnose the disease. But if it's not there, it doesn't mean that the disease is not there. These are his xanthomas and his feet and hand. This is after the apheresis. So Turkey was lucky. We could catch him early. Well, we can say early. You know, we could help him. He is now about 6-7 years. On plasma exchange. He did not have any cardiac event. He was never admitted again in the hospital. We did CT angiogram to his coronaries, and it's very clear. And his aorta and aortic valve is being checked every year, and it's fine. There's no stenosis. So Turkey was very pleasant guy, and he came and invited me to his wedding, and unfortunately, he got married to his first cousin. The bride also lost 3 of her brothers to the disease. So let's sum up our talk. The prevalence of FH in other population of the Arabian Gulf region is very high. And of course, we know because of the high consanguinity there. Xanthoma may be misdiagnosed or ignored as a skin lesion, and as we see, you know, it's started with the xanthoma and sent to the wrong subspecialty. Then that's why we need to increase the awareness of the disease among our healthcare practitioners, our colleagues. So we had a paper published recently about xanthomas can be misdiagnosed and mistreated in homozygous FH. This is a call for increased awareness among dermatologists and healthcare practitioners, because they are the first line who are receiving these patients, and they can refer them to us. The need of educating the population also is very important, using the social media and maybe webinars like the one we are having today. And the Gulf FH registry, after we got the result, you know, it's a first of a kind multinational study in the Middle East, and will potentially, the numbers we have, you know, will help improving the gap of underdiagnosis and undertreatment of FH patients in the region. Thank you very much. I urge you to visit this lovely place after opening the lockdown. It's Madain Saleh and the UNESCO World Heritage. It's lovely, and you can come in the winter and visit, especially Raoul, you know, and he's very welcome to come. Thank you very much indeed.
Thank you very much, Dr. Fahd Al-Nouri, for a very elegant and thorough review of the topic of the familial hypercholesterolemia, and particularly our local data. We'll be entertaining questions as they appear, but let me ask you, Fahd, before we move on to Raoul, do you think there are other reasons other than consanguinity and consanguineous marriages for the high prevalence of FH in our region? Are there other factors that can affect the prevalence that have been reported internationally? You already showed us that it really depends how extensive you basically do your screening. Like the Netherlands, they do a great job. So could a country get a false, apparently low or apparently high prevalence depending on the way they do screening, like cascade screening, index screening, the different types of screening, how extensive the screening, or other factors?
Well, consanguinity plays a major role, Khalid, you know, in this disease, because it's an autosomal dominant disease. For mutation, I mean, even the known mutations, when you do it, you know, it's not 100%, it's 80% patient with definite FH, you know, so we can miss 20% in the genetic testing, you know. So there are multi-roles, you know, but we have to put in mind that when we diagnose an FH, we have to diagnose it as a monogenic, because the polygenic FH, there are some other causes, the secondary causes like hypothyroidism or obesity or all these things, So I think, from my experience, and consanguinity plays a major role. Maybe Raul has another point of view.
No, actually, every disease, the more you look for it, you find it, right? So I guess that depends on how much you look for it. Of course, consanguinity is extremely important, specifically for the homozygous FH patients, right? Because you might get one affected allele from each parent and increase the frequency of the disease, right? So this is, I think it's important. I see, the registry that your guys are doing, it's extremely important to really show what's going on in the region, and specifically because not only of that, but because also have an epidemic of obesity and type 2 diabetes.
Yes.
In your region, and then you mix the bad genes of high cholesterol with diabetes, I think the consequences actually may be even worse. So that's it, right?
So Raul, let me ask you, and Fahad as well, the other question is, for the practicing physician, he might ask, well, do I need to do genetics? I don't have access to genetic studies, and they are expensive even if I want to do it. So how accurate it is to just depend on these clinical criteria like the Dutch lipid clinic criteria or the Simon Broom and others without doing genetics necessarily? Obviously, if you have genetics, that's great, but classically and typically, we don't have access, all of us, to genetic studies
it's
all
very
over the world.
You're right. The one test for the proband, it costs about $1,000 in our country. And mind you guys that we have only 2 centers in the Gulf, one in Makkah al-Mukarramah, Al University, and one in Oman with Professor Khadr Asadi, Makkah with Professor Faisal Allaf. So the access is very difficult, of course.
So we can depend on clinical criteria only to diagnose
because of the expense of the test, and the fact that 80% of the mutation can be detected and 20% can be slipped away.
So can still get negative genetic testing.
Exactly,
right?
exactly.
Even with very high LDL.
Yeah. So with increase of the awareness, phenotypically we can diagnose the cases, and we can start, counseling for the patients and start treating, And Raul just pinpointed very important point that diabetes is a pandemic in our area. So
Raul, the situation different, Raul, in Brazil and internationally in terms of genetic testing?
Oh, no, actually, no. Actually, only in some European countries that are very advanced, like the UK or Spain, that they do that routine. Even in the Netherlands nowadays, the government doesn't pay anymore for the genetic test. So it's a pity. I'm going to show in my talk that actually the genes can make the difference, especially when we're talking about risk. But for us as clinicians, what really matters is the high cholesterol. And actually, we talk about cascade screening because it's very important, because we find people affected in the families and we can start treating very early. But I'm totally in favor of doing universal screening so we can check cholesterol of everyone. And of course, if we suspect FH on the clinical ground, because usually those people, they have family history of dyslipidemia, family history of early coronary heart disease. As Fahad shows, some of them might have xanthomas, maybe 15% of them might have xanthomas, right? So we can identify, because for the individual, if I find someone with high cholesterol, I'm going to treat, right? There's no doubt about that. But for the family, actually, the question is, should I call the relative, the brother, the sister, the son to check cholesterol? And that's the thing about FH, because if we make an early diagnosis, we can start treating early, and in the end, we can make a lot of difference. I'm going to show you very interesting data from the Netherlands that they started treating kids with FH. And actually, those kids had a much better prognosis than their parents.
Yeah.
So this is quite interesting. I like very much the idea of genetic testing because it's okay. So we can our cascades might be more effective. Actually, might find higher risk patients than people who have pure hypercholesterolemia where we don't find the cause. But I know it's a challenge. Here in Brazil is the same, you know, so I have it in my center because we got funding for research, but if the money is not available anymore, I won't be able to check, but I'll keep doing cholesterol in my patients and finding them.
So LDL is good enough, I guess.
Yeah, risk is, the LDL is great, right? When we're talking about risk.
And by the way, it's the LDL is very important because it's not the matter of the severity of the gene, it's the matter of how high the LDL is. So you might find like the LDL receptors, which we think that this is the most common and most detrimental gene, but you find them, their cholesterol is not as high as like an heterozygous, you know. So some heterozygous are very severe, and you need to treat them. I mean, very.
Or the other way around, you can have homozygous with with not necessarily very high LDL.
Exactly, especially if they are compound heterozygous. The gene comes from different families, you know. So it's not true homozygous. They have some defective receptors. It's not negative or null receptors like the true homozygous.
Okay, great, my dear colleagues and friends. So thank you very much, Dr. Fahad Nouri, for your great talk. So let's move on, for the sake of time, to our dear colleague and friend, Dr. Raul Santos. Raul has visited our region and our country many times and has been really a great supporter for our educational events and symposia and conferences. So without further ado, I would like to move on to your talk, and looking forward for your talk, Raul.
Thanks so much, Khalid. Salam alaikum, everyone. It's really a great pleasure to be with you. I've been a few times to Saudi Arabia, had very nice moments, very friendly people, and I'm really honored to be invited to participate in this webinar. And sincerely, inshallah, I hope we can be together again in the future after this.
My Spanish is not very good, so the only thing I know is hola.
Oh, good. Okay. So my friend, let's go. Just let me share my screen and okay, where is my PowerPoint here? Okay, so basically the idea is quickly discuss with you how we can identify higher risk FH patients than other ones, because even considering that FH is a disease that is associated with a greater risk of cardiovascular events, you see there's some heterogeneity among these patients. We have FH patients that have much higher risk than other ones. And this might have implications, especially with the newer treatments that are very effective, but are very expensive. So this is my disclosure, conflicts of interest. So actually, we know that FH means high risk, right? Because when we didn't have the statins, if we didn't treat male individuals who had FH, by the age of 50, probably 50% of them would already have coronary heart disease or died, and around 25% of women. So it's a disease that really makes atherosclerosis come 10 to 20 years earlier than the usual population. And we were discussing about what's the most important thing, the mutation or the cholesterol? Actually, of course, it's the cholesterol, right? Because high cholesterol is what causes atherosclerosis. But it's interesting that actually among people that have high cholesterol, we have individuals with greater risk. This is a very interesting study that was done on some genetic biobanks. And as you can see here, we have two groups of individuals, those who have an FH causing mutation in purple and those who don't have in blue. And as you can see here, as cholesterol gets higher, there's a greater risk of coronary artery disease. But when we compare actually those that we have a mutation, you see that even for those individuals who have very high LDLs, let's say between 190 and 220, or even greater than 220, actually those who have a mutation have a threefold greater risk of cardiovascular events when compared with hypercholesterolemic people that don't have a mutation. And when we compare individuals with low cholesterol and who don't have a mutation, it's up to 17 and 26-fold greater risk. So one can say, okay, high cholesterol means a higher risk, but if you have FH, it means a higher risk than that. And why is that? Usually because when you have FH, you are born with high cholesterol and you're exposed to high LDL cholesterol levels since you're very young. So you're gonna get disease earlier and you're gonna get a more severe disease. Of course, as I said, we as clinicians, what we do, we go for the family history, for the patient's history, we go for the cholesterol, and we have an idea of what's going on. But actually, genes are important because some genes are really very bad to our health. We know that actually the severity of the FH phenotype depends on the severity of the, I'm not say 100%, right? Because it's not only the genes, but also diet, exercise, if you're fat or not. There are other effects that might get together with the genes in order to give you a bad or not so bad phenotype. But actually for FH, that depends on the number of affected alleles, right? Okay, you might be a heterozygote FH patient, but if you have a new mutation and you don't express the LDL receptor in 50% of your liver cells, so you have high cholesterol. And if you have two affected alleles, and if you're two affected new alleles, actually you're gonna have very, very high LDLs, maybe like 800, 900 milligrams per deciliter. And of course, heterogeneity depends on the kind of mutation that you have. And it's interesting that actually not only the LDL receptor mutations are causes of high cholesterol, but also we have other genes that actually may influence on cholesterol levels. And we know that actually that around 20% of people that have an FH phenotype and where we don't find the classic variants in LDLR, ApoB, or PCSK9 actually have high cholesterol because of polygenes, right? So there's a small number of genes that get together, and each of these genes with small effects actually make cholesterol go high. So you can inherit not only the classical autosomic dominant, but also you can inherit from your parents these polygenes, right? And we can put these polygenes into a score and have an idea of the severity of the impact of these genes on LDL cholesterol. And this study here was very interesting because actually they got patients in Canada that had a phenotype of FH, and in some of them they actually found the monogenic variants, the classic FH. In some of them they found a high polygenic score, and in some of them they didn't find any of these genetic alterations. And actually in a group of people, actually they had either the monogenic variants and also the polygenics. So actually they have different genes working together to raise cholesterol. And one thing that they found is actually the severest patients, those who have early coronary heart disease, actually were those who had the monogenic variant associated with the polygenic. More genes to raise cholesterol, greater risk. And that means that actually the variability on the phenotype and on the consequences of having FH actually might depend not only on if you have a monogenic defect that makes your cholesterol get higher, but also if you have other genes that add deleterious effects on high LDL cholesterol and you have a greater risk. Interesting, not only those genes actually that raise LDL cholesterol can make you have a greater risk of cardiovascular disease. We know from the work of Dr. Sek Katirizan from Harvard Medical School that actually we have other genes that have nothing to do with cholesterol that might increase your risk of developing atherosclerosis. And when you get these genes together into a score, you can identify individuals that will have a greater or a lower risk of developing cardiovascular disease as time passes. And here, this is very interesting. This is not, data was not yet published, but this is quite interesting because here in blue, we can see the risk of coronary heart disease of those who have FH. So it's higher than those who don't have FH. Here you can see in brown. But actually, if you get not only the genes that raise LDL, but also the genes that raise the risk, and you get them all together, actually you're gonna see individuals with a higher risk than only having FH. So if you have those genes that raise your risk of cardiovascular disease in association with your genes that raise LDL, you're gonna have the greatest risk of events. On the contrary, even if you have FH, okay, and you don't have these genes that raise the risk, actually your risk might not be so high, right? And actually those individuals who have the lowest risk were the ones who neither had FH and nor had the coronary heart disease genes. So it's quite interesting. As you can see, this heterogeneity in phenotype, that's not only LDL, actually on other genes, actually lifestyle, actually other risk factors that can make you have a higher risk of developing coronary heart disease. Of course, other risk factors make a lot of difference, not only for people who don't have FH, but also who have FH, because let's say if your LDL is 300 milligrams per deciliter and you smoke or you're hypertensive, you're gonna get a greater risk of people who have only high cholesterol. So we can get this together in a score like we do with the Framingham risk score or the pooled equations, and you can have one score that is specific for FH, that is the Safe Heart. This one was developed by the Spanish group Pedro Mata. And actually you can see here that the older you are, if you're a male, if you have previous atherosclerotic cardiovascular disease, or if you have family history, if you're hypertensive, if you're obese, if you smoke, if your LDL is still high despite of treatment, and also if you have high Lp weight, you're gonna get a greater risk of developing cardiovascular disease, even if you have a background of high LDL. So we can use also these risk factors to identify higher risk FH people. And what about imaging? You know, because before you have a heart attack, before you have an MI, first you have to develop atherosclerosis. And we have many studies actually in non-FH patients showing that you have plaques, right, in your coronaries or your carotids, you have a greater risk of having an MI, a stroke, or even dying because you develop the disease. And we have also people that have risk factors, but actually don't develop plaques. And these individuals have a lower risk of having events. The question is this true also for FH? So we just published this meta-analysis of FH patients, around 1,100 patients who had FH, most of them in molecular diagnosis. The residual LDL was around 158 because 97% of them were taking statins. And we found interesting that actually 45% of patients who had FH didn't have coronary plaques. They have a calcium score of 0. This showing there's heterogeneity, right, in the risk. Remember when I told you that before the statins, up to the age of 50, probably half of men would have had a heart attack or died. So that means that the other half did not, right? That doesn't mean that we don't have to treat those individuals who have high cholesterol and didn't get plaques or didn't have an MI. But that means that there's heterogeneity in the risk. So that we have people that are more susceptible to develop cardiovascular events than others, even if they have very high LDLs. And the question that comes, okay, if let's say 45% of FH patients don't have subclinical atherosclerosis, does it mean that those individuals have a lower risk of developing an event? And on the contrary, if they already have plaques, do they have a greater risk? The question probably is yes. This is something that we published actually last year. So we have 200 with molecular diagnosis. Everybody was being treated because we're not crazy of not treating high cholesterol, okay? So we treat everyone. And as you can see here, those patients who actually had atherosclerotic events were the ones who had coronary plaques, were the ones who had subclinical atherosclerosis. And those who had a calcium score of 0, up to a follow-up of around 4 years in median, actually didn't have any vascular events. This suggests actually there's this heterogeneity indeed exists. And that actually, this might help us to identify patients that might need the newer treatments. Because we're not saying, do not treat someone who has FH and doesn't have plaques. You have to treat, you have to reduce the LDL. But maybe, let's say if you don't have the money to pay for the newer treatments that are very expensive, right? If you find someone who doesn't have subclinical atherosclerosis, you might not need to prescribe maybe a PCSK9 inhibitor, even if the residual LDL is to 150 milligrams per deciliter. So this is something that might help us guide treatment. And also, these individuals that don't develop atherosclerosis, these individuals must be studied. We need to check their genes. We need to check other risk factors to really understand why someone who has a baseline LDL of 250 doesn't develop atherosclerosis. So these are very interesting questions that we need to answer. So actually another way of really identifying an FH patient who would have a greater risk of developing events actually is mixing up presence of plaques, presence of subclinical atherosclerosis, and also the classical risk factors like smoking, blood pressure, HDL, diabetes, and so on. So one thing that you can do, if you take a look at the vessel and you determine the amount of calcification, is really to determine the, let's say, the biological age of that artery, not the chronological age. You remember the MESA study, multi-ethnic study in atherosclerosis? Actually, they were able to identify and compare the ages of individuals who had plaques or not. And let's say if you have plaque, certainly you are older than your arteries. If you don't have plaque, probably you're younger than your arteries. So you can use that and calculate a vascular age score. And you can use that instead of using the biological age, the chronological age, and you can calculate a risk, let's say, that's more accurate because you have the idea of what's going on with the arteries. And basically that's what we did. Here we, on the same population that we followed, here we use the classical Framingham risk score, where we separated patients in low, intermediate, and high risk. And here is the risk scoring using the vascular age instead of the chronological age. And you can clearly see here that we had a much better way of identifying those FH patients who are going to have a heart attack or dying or being revascularized when we compare with the biological Framingham risk score. And the discrimination had an area under the curve of almost 0.9 in comparison to 0.7 of using the classical Framingham risk score. So this is a way of really helping on how to identify a higher risk FH patients. So what about the severe and less severe phenotype? So can we really stratify the risk of cardiovascular events even in a high risk population as FH? The answer is yes, we can. That depends, of course, not only on the values of cholesterol. The higher the LDL, of course, the greater will be the risk, but also that depends on if the individual already had a cardiovascular event or have subclinical atherosclerosis or has other risk factors like smoking, low HDL, and late treatment, and so on. And you can see here that even in an individual who has FH, there's this big heterogeneity in risk. And one thing that is clear for me is actually if you have a monogenetic defect, probably you have a greater risk than if you have polygenic hypercholesterolemia. Let's say that between FH and the polygenic, we might identify 30% of hypercholesterolemic patients, and around the rest, 70%, we don't know the cause yet. We don't know, okay? But if you have a monogenetic defect, you have a greater risk. And if you have association of other risk factors, the risk will be higher. Okay, so what about treatment? Should we treat these individuals? Yes, the answer is yes. We always need to treat FH patients, even if they don't have the other risk factors, even if they don't have subclinical atherosclerosis. This is something that simply we cannot afford to do. The question is, okay, should we be more aggressive depending on the individual? So do statins make the difference for these patients? Yes, they make a lot of difference. This is data from the Netherlands, 12 years of treatment. The LDL was reduced by around 40%. And you can see here that these are the FH patients who were not treated during here in orange. So they had around 30% of events during 12 years of follow-up. Here in green, we have the usual people from the Netherlands that participated in the Rotterdam study. And in blue, we have the FH patients that were treated for 12 years. And as you can see here, there's a huge reduction in the risk of events if we reduce the LDL. Okay, we don't put those patients at the goal, less than 70 or less, I don't know, 50 milligrams per deciliter. But if we reduce an LDL by 40%, we can make a lot of difference. And there's no longer a difference on the risk of event between FH patients and the general population in the Netherlands. This is data that was were published last year, and this is beautiful data because actually these are children who became adults and were treated after the age of 13 years old. And here you can see the risk of events in their parents that actually these individuals were all identified in cascade screening in clinics in the Netherlands. So basically they found a young parent who had FH and also who had a heart attack or was revascularized and so on, okay? And actually these parents were not treated 30 years ago because we didn't have drugs, we didn't have the statins, so, and then they identified the children by cascade screening. And then these children actually started treatment very early, by the age of 13, right? And these children became adults and they were followed by 20 years. And as you can see here, actually, when we compare these children who became adults with their parents, we can see that actually just 1% of those children who became adults had cardiovascular events in comparison with around 30% of the parents. So they really were able to reduce the risk of events. They started treating those kids. They reduced LDL by around 30%. And actually, these kids were followed by 20 years. They become adults and they didn't have cardiovascular events. So that's the magic with FH. You identify higher risk, young individual, and you start treating, and you can make a lot of difference for these kids. Okay, so what about the newer treatments? We know that actually statins are very good for FH, but sometimes we have individuals with very high LDL cholesterol levels, and statins are not enough, ezetimibe is not enough, and we need other treatments. PCSK9 inhibitors actually really can make the difference for FH, and actually if there's one disease that these drugs can really make the difference is FH, because we can reduce LDL at least by 50 to 55% in heterozygous FH patients, and by around 20 to 25% in homozygous FH patients. This is data that we published this year for 4 years follow-up of not only homozygous FH, but also severe heterozygous FH, most of them already with coronary heart disease. And we can show here that can reduce LDL cholesterol, and also we can reduce the risk of events. If we compare the annual rate of events of patients in Taussig, these rates are a lot lower than the ones of FH, historical FH patients in the past that were not being adequately treated. So we don't have a randomized clinical trial saying that statins can reduce the risk or PCSK9 inhibitors can reduce the risk of cardiovascular events in FH, but observational data actually, if you're high risk, you already have coronary heart disease, and if you add a PCSK9 inhibitor, you can really reduce the risk of these individuals. So interesting that actually there's heterogeneity on the response, because I showed you average reductions in LDL, but as you can see here, especially here in homozygous FH patients, we might have patients who might not even respond at all to treatment. We actually have some crazy patients that LDL goes up with treatment. Probably this is where individuals who said they were taking the statins, but actually they weren't, or they stopped the statins during the treatment, so LDL went very high. And you can see here that depending on the molecular defect, you might have a greater or a lower response. But actually, even for individuals with the same molecular defect, you might get greater or lower LDL reduction. So this is a little bit complicated. And this is for the heterozygous FH patients. As you can see here, we have greater reductions in LDL. The LDL mutation doesn't make so much difference for this patient, because actually one of the alleles is normal, the other one is affected. So the normal alleles of the LDL receptor will overexpress the LDL receptor in the liver when we give PCSK9 inhibitor. But as you can see, there's a lot of heterogeneity also. We have patients that might reduce LDL, let's say, by 10%, another ones will reduce LDL by 90%. So this is something very interesting. And the only way of really ascertaining this is to give the drug and see what happens with the patient. So we have to treat and see what the response will be. So what about the future, right? These PCSK9 inhibitors that we have nowadays, alirocumab and evolocumab, we give them every 15 days or once a month. But now we have this new treatment. This is small interference RNA against PCSK9, that's inclisiran. Basically, this one degrades the messenger RNA for the PCSK9. So we have a reduced production of PCSK9 in the liver, and we have less PCSK9, and we have a greater expression of the LDL receptor on liver surface, and the liver will be able to remove more LDL from the circulation. This is different from the monoclonals, because basically what the monoclonals do is they bind the circulating PCSK9, and this complex is removed. So we have less, let's say we take because that they will be, the circulating PCSK9 will be inactivated. With inclisiran, actually, you won't produce PCSK9. So we will secrete less PCSK9. And as you can see here, we can have around 40 to 5% reduction in LDL cholesterol level. And the good thing about this treatment is actually in the first year, you're going to give 3 shots. And in the second year, you're going to give 2 shots only. So imagine being able to control cholesterol with 2 injections per year. This is amazing, amazing. And so far, we have no evidence that this is harmful, because differently from the monoclonals, this drug, inclisiran, concentrates into the liver, right? And so it alters the synthesis of PCSK9 inside the hepatocyte. And one might ask, oh, might this be deleterious, right? Because the monoclonals, they simply bind into the plasma and they don't get into any tissues, right? This one gets into the liver. But so far, we have no evidence at all that this will be harmful. And I guess probably this drug will be probably approved in the United States next year. So what about the future? Actually, there are many drugs that are being evaluated in pipelines. And one that is quite interesting that actually is being developed initially for the homozygous FH patients, because remember, homozygous FH patients, they don't respond very well even to PCSK9 inhibitors. And as Fahad said, we need the LDL apheresis for these patients, because LDL apheresis is the best treatment for the severe homozygotes, right? But what about other drugs, right? There's a protein that's called ANGPTL3. And actually people who have loss of function variants of ANGPTL3, they have one state. I'm not going to say that's a disease. I'm going to say that's a state, because actually those individuals have a lower risk of developing cardiovascular disease. So these people that have hypolipidemia or hypolipemia, they have lower values of triglycerides, cholesterol, and HDL. As you can see here, if you're a mutant for this ANGPTL3 and you have one allele, you have lower LDL, lower triglycerides, lower HDL. HDL not so much different, but if you have both alleles affected, you have much lower values. And we have studies that follow these individuals for their lifetime, and they have much lower risk of cardiovascular in the usual population. And actually, they developed one drug, one monoclonal antibody against ANGPTL3. And guess what? They tested that in homozygous FH. And this is interesting because actually, there's no evidence that ANGPTL3 has anything to do with the LDL receptor. We don't know how these individuals will have lower expression of ANGPTL3, have low cholesterol. We don't know why and how, but actually in the end, they have low cholesterol. And actually, Professor Frederick Rao, also a good friend of us, presented this data at the last ACC, and this is going to be published in the New England Journal of Medicine very soon. And actually, they got homozygous FH patients, refractory, they were doing plasmapheresis, they were taking lomitapide, some of them were taking PCSK9 inhibitors, and these individuals were randomized to have weak injections of evinacumab, that's the monoclonal antibody against ANGPTL3, and placebo. And they were followed for 6 months. Interesting, differently from the classical monoclonals that we have, this has to be injected intravenously. They don't have subcutaneous injections for this one yet. And this is what happened to the LDL cholesterol here. This is, you can see this is the placebo, and this is those patients who took the evinacumab once a week. So there was a 49% reduction in comparison with placebo. This is amazing, you know. So patients were taking everything. They're taking lomitapide, PCSK9 inhibitors, statins, many of them apheresis, and we got a 49% extra reduction in LDL cholesterol. So many of these individuals actually became with LDLs less than 70 milligrams per deciliter, something that we never thought that could have occurred for a homozygous FH patients. And much better, even for those individuals who do not express LDL receptor at all, who are the most severe ones, who have no new variants, the drug works exactly the same for those who have defective variants. So this
Rahul, I hate to interrupt you, but could we wrap up to allow some time?
Yeah, we're at the end, yes. We're at the last slide, actually.
Great.
So Yeah, so to conclude, okay, FH is a disease that has a high lifetime risk of cardiovascular disease. However, there's heterogeneity in this risk, depends on the LDL cholesterol, other genes, other risk factors. If you have subclinical atrophy, we have a greater risk. Statins save lives in FH, make the difference. However, some patients might need these newer treatments, and we have to identify the highest risk patients and treat them adequately. Shukran, my friends. Thank you very much.
Thank you very much, Dr. Raul Santos, for very interesting data and intriguing data. And the more we learn about genetics, the more little I discover I know, I guess. Looking forward for more very exciting news for our patients. Hopefully, these newer treatments will be shown to be safe, which is a major concern with these novel therapies. May I ask you quickly before I go over the many questions that we have, and then we'll go back and forth between you and Fahad in the last 8 minutes remaining in this webinar. What do you think, Raul, about the current classification of FH in the latest European Society of Cardiology guidelines, dyslipidemia guidelines, 2019? They have been divided only into 2 groups, FH with risk factors and FH without risk factors. FH with risk factors or heart disease, you're already in the very high risk, while those with FH but no heart disease or risk factors are in the high risk. So only dichotomous, very high risk and high risk. Now, according to your presentation, is that an oversimplification of the FH patients?
Oh, that's a great question, Khalid. Actually, you know, if you compare FH with a non-FH population, the risk is usually higher for most individuals, right? But actually, we have higher risk individuals, and this is true. Okay, I think in a practical point of view, for us as clinicians, the difference is okay. FH, you treat, you give statins, you give ezetimibe, you do LDL at least by 40 and 50%, right? But should I give these other patients the other more expensive medications? That's how I see that, you know, in a practical way. So if a patient already has cardiovascular disease, this is very high risk. So you have to treat. Many other risk factors, risk might not be so high, but definitely higher than the ones who don't have risk factors. So probably also have to treat either. So that's how I see things, you know. But, you know, there's many, let's say, gray, between black and white, there's a lot of gray, even in FH. That's what I want to say. You know?
Can I comment here?
Quickly, Fahad, because we want to take as many questions as we can.
Okay, and there is one also very common question. I'll come to it. The patients with FH and diabetes, you know, they have 16 times more of developing atherosclerosis vascular disease. And if you add smoking on top, that will quadruples, you know, 4 times more with the diabetes and the smoking, you know. So we have to treat these patients. Khalid, allow me please, there's a very interesting question here for patient with dyslipidemia, with strong positive family history, and also the patient had diabetes type 2. If the levels are normalized, maybe they think about the cholesterol and diabetes, with the statin, until when the statin will be used? You know, I mean, statin will be used for good. Statin and ezetimibe, of course, you know. I mean, it's not like an antibiotic. You take the course until the disease is eliminated, you know. So please, we have to be sure that the statin is taking for life, you know. This is very
So, Fahad, since I have you now, Dr. Fakhr Al-Ayubi is asking how long the process of plasma LDL apheresis takes and how long the normal LDL levels stay.
Okay, every session will take about 3 to 4 hours. It depends upon the body surface, and it's twice per month. We are doing it twice per month. You know, some people doing it every month. And what's the other question, Dr. Khalid?
How long the normal LDL levels stay?
It's, as you can see, you know, when the first case, the Turkey, we have the ticket is from the first session. First session, it drops down like 50 to 56% after that. But after like the curve, normally 10 days, you know, it will come back again. So that's why we are doing it every 2 weeks. And
there was a quick question. Did you advise Turkey not to marry his relative?
Well, I tried to, but unfortunately. You know,
you did, but he didn't.
He got a baby boy, by the way, 2 months ago, but because of the corona, we couldn't test him.
Okay, you need to test them. Raul, is omega-3 beneficial in dyslipidemia and hypertension? Very interesting topic of hypertriglyceridemia.
Yeah, actually,
which is probably another whole talk by itself.
Yeah, definitely. You should invite me.
Yes.
Okay, so yeah, it depends on the dose, right? Actually, if you have high dose omega-3, purified omega-3, 2 to 4 grams per day, you might reduce triglycerides by up to 30%. But the question is, does that reduce cardiovascular events? That's the question, you know? And actually there's, if you give statins for these patients, probably low dose, 1 to 2 grams won't make any difference for these patients. But let's say if the triglycerides too high, over the 150, high risk, taking statins with high triglycerides, still high triglycerides. Actually, there's one drug that is called isopentyl EPA, right? Isopentyl EPA, right? And if you give 4 grams of this drug, this might reduce the risk of cardiovascular events by 25%, as was being shown in the REDUCE-IT study. So it's very specific population, just one type of drug, very purified.
Yeah, in the REDUCE-IT trial published in the New England Journal of Medicine, those with diabetes or chronic heart disease, giving 4 grams of the drug is called Vascepa. It's not introduced in the kingdom yet. It's under approval process, but only those with high triglyceride reduced cardiovascular event. But it's only one randomized trial. There was another Japanese, the Julius trial, but it was open label and kind of softer endpoints. Moving to Fahad, he's Ahmad Zamir is orthopedic surgeon, and he said this is the first time to know xanthomas about the and the issue and related to on tent, because you know orthopedic surgeons examine these areas of the body, and he said this is the first time to hear about that and the relation to FH. So this is encouraging and very interesting from educational point of view. Nader Ghunaim saying any role for genetic engineering therapy in FH? Raul?
In the future, probably. We don't have yet. They're trying to actually put normal LDL receptor genes into viruses and inject these viruses in homozygous FH patients to see whether they work. Sometimes we don't have, but maybe. And also CRISPR. They're trying to
CRISPR-Cas9, they use it, but it's hopeful.
Yeah, it's still very, in the beginning.
Yes,
so
in infancy.
Please, give medication.
It's infancy yet.
Yeah.
Great. Basically, there are many questions. I guess maybe we can put them to you later on, and you can try to answer them if you can, because we're out of time. Thank you very much, both of you, Dr. Fahad Al-Nouri, Dr. Raul Santos. It has been really very educational event. A great pleasure to have you both. Thank you very much. Take care and stay safe.
Thank you.
Thank you, my friends. Thank you.
Thank you. Goodbye. Assalamu alaikum.